Hello, everyone, and welcome to the 88th episode of the Royal Society of Medicine's COVID-19 series, which is for health professionals by health professionals. I am Dr. Callum Phillips. I use he and they pronouns. I'm the LGBTQ lead and deputy editor-in-chief of the British Student Doctor Journal, a BMJ Clegg scholar and advisor to GLAD, the Association of LGBTQ Doctors and Dentists. First, some quick housekeeping. Please do use the Q&A feature to ask questions during the session, and you can upvote those that you'd like to see answered. In this hour, we're going to be discussing LGBTQ health and care in the pandemic, and this will be recorded and available on the RSM YouTube page. I'm joined today by our wonderful panel who I'll hand over to introduce themselves. So first, NHS England's Lizzie Streeter.
Hi there, I'm Lizzie Streeter. My pronouns are she, her, and I'm the National LGBT Programme Manager at NHS England. I work with Dr Michael Brady, who was appointed in 2019 by the Government Equalities Office as the first National Advisor for LGBT health.
And second, GP in London and at the Tavistock Gender Identity Clinic, Dr Kamilla Kamaruddin.
Hello, hi, good morning. Yes, my name is Dr. Kamilla Kamaruddin. I'm a GP in London and also at Tavistock Gender Identity Clinic, and I advocate for better healthcare and human rights for trans people.
And finally, closing off the panel, the LGBT Foundation's Paul Martin.
Good afternoon, Callum and everybody else. Really pleasure to be here. My name is Paul Martin, pronouns he and him, and I'm the Chief Executive of LGBT Foundation. And LGBT Foundation was established in 1975, and we exist to support the needs of the diverse range of lesbian, gay, bisexual and trans and questioning people. We believe in a fair and equal society where all LGBTQ plus people can achieve their full potential. And we're a nationally significant charity firmly rooted in our communities of Greater Manchester, providing a really wide range of services. And each year we support over 40,000 people. And the pandemic has done nothing to diminish that, I can assure you.
Well, welcome everyone. I'm very pleased to have you all here. I think it'd be a good idea first if I set out a little bit of background and how we'll be approaching conversations on LGBTQ health in this webinar and unpack some of the language that we'll be using, and then we can get into the questions for the panel. If it is possible to remember as far back as pre-COVID, we know that LGBTQ people in the UK already faced worst experiences of, outcomes from, and access to healthcare. Despite legal protections, discrimination and inequalities continues to impact LGBTQ patients who report harassment and pressure to fix their queerness. The NHS has still failed to initiate an effective national data collection and monitoring system to allow for evidence-based decisions and progress to be made. Our initial attempts to increase inclusivity, such as rainbow lanyards, have both been co-opted by the pandemic response, shifting their role in allyship to the shadows, while also failed to address the root causes of a culture of exclusion. These harms do not impact LGBTQ people uniformly. In having this discussion, it's important that we take an intersectional approach when considering these systems. Use of the word queer in this webinar will be deliberate, in that it reclaims power from a rigid hierarchical structure in the UK, which places the cisgender, heterosexual, white, able-bodied male at the top. Queerness exists along a spectrum, encompassing a range of identities and experiences. The further a queer individual strays from society's ideal, the more likely they are to be discriminated against, and the higher the societal discomfort and the more barriers they will face to thrive. And so in any discussion, and especially this discussion about queer progress, we must not center on society's acceptance of the most palatable version of queerness, the cisgender white middle-class gay man. So with that, let us turn our minds to COVID and delve into this Royal Society of Medicine webinar, LGBTQ health and care in the pandemic, and our opening question. So what health needs and experiences have the queer community faced during the pandemic, and how has that differed from the cisgender and heterosexual population? And I think if we start with Paul.
Thanks, Callum. Well, you've already started to answer that question from my perspective. We know that COVID has affected everyone, but we also know that the impact of COVID hasn't been equal, with disadvantaged communities being the most hardest hit. You touched upon monitoring. We knew that there were a number of health inequalities being experienced by LGBTQ plus people prior to the pandemic. We know that LGBTQ plus people have got a high proportion of pre-existing health conditions, are less likely to access health services, and are much more likely to be living either on their own and or in insecure accommodation. So we knew that there was a raft of health inequalities already and prior to COVID, but COVID has only increased those really. You mentioned about monitoring. We don't have widespread sexual orientation monitoring across health and care services, and trans status monitoring is almost is not very much there at all, hardly exists at all. So I think that it's quite hard to kind of build that picture. The LGBT Foundation, alongside other organisations, did try and do some research. We did a piece of work last year looking specifically at the health equality needs of LGBTQ plus people during the pandemic. We definitely called Hidden Figures. There's more information on our website, and I think there's going to be some links shared later. But we definitely kind of got a sense that COVID disproportionately impacted on LGBTQ plus communities, particularly in terms of mental health and isolation. 42% of the people that we survey said that they wanted access to mental health services but were being denied. That rises to 66% of queer people of colour and 57% of trans people. And I think what we're also very aware of is that when people's intersectional identities come into play, then we have a greater, higher level of health inequalities as well. We saw a significant rise in alcohol and substance misuse, and certainly from my own organisation services, we saw a number of people that had already been in recovery actually coming back into the services. And certainly, as I mentioned in the opening, the need of our services have only grown during the pandemic, particularly our domestic abuse, our drug and alcohol services, and our mental health services. Numbers have really grown, and we are continuing to see quite steep rises as well. We're really clear that not only mental health was having a detrimental impact on people's health and well-being, but we found that people's feelings of isolation were just compounding that. And we particularly have got evidence around the needs of older people who are much more likely to be isolated and on their own, particularly if you cast your mind back during those very long stretches of time when we were in different lockdowns. People were quite isolated, and also there were a number of people that were in quite insecure and quite dangerous settings. So I think it's really true that we have got some fairly weighty evidence to sort of demonstrate that LGBTQ plus people's existing health inequalities have only grown and only have been added to, and I think particularly we have some real concerns about what happens in coming years of COVID on people's mental health and well-being.
And I wonder if Dr. Kamaruddin would like to weigh in, particularly for trans people, how they've been impacted.
Yes, firstly, I would like to read out some of the experiences of trans people when accessing healthcare before the pandemic. The Stonewall's LGBT Health Report in 2018 stated that 37% of trans people avoided healthcare, 16% being denied healthcare because of their gender identity, 46% have suicidal thoughts in the last year, 12% have attempted suicide, 67% have experienced depression in the last year, 71% have experienced anxiety symptoms, 41% of non-binary people have said they have harmed themselves, and 20% of trans people have witnessed discriminatory remarks against LGBT people by healthcare staff. And this is before the pandemic, and we know that the pandemic has posed many challenges to all of us and has affected our mental health and well-being. It is causing significant distress and worsening mental health and economic uncertainties, and also disruption to access health services. And like Paul has said earlier, that in the LGBT survey, found that 42% of LGBT survey respondents said they would like to access mental health services. And the figures have risen to 57% among trans people and 60% on non-binary people. And so, I mean, I expect that these figures are likely to increase. And so, I mean, LGBT and trans people have experienced more high levels of isolation. There were times that previously when they would able to access a lot of support in community centers or community groups, but now, during the pandemic, they have to isolate themselves. They're not able to access these, lovely, wonderful, and supportive support groups, and also issues about safety. And I think between 23rd March and April, 12th April, LGBT Foundation Helpline seen a 100% increase in calls about transphobia. I mean, these statistics are shocking to hear, to know about it. And there's a lot of health inequalities. I mean, the NHS England have done a lot of survey and have done a lot of studies about inequalities among other minorities, like among the BAME minorities, among women, but there was hardly any surveys or any reports conducted by NHS England themselves about LGBT health during the pandemic. And to me, this suggests that that there's still these inequalities among LGBT people are not actually acknowledged fully by the NHS England, and I think that something should be done about it.
I suppose that begs the question then, Lizzie, why has this been such a sort of charitable response by such LGBT foundation rather than an institutional one from the NHS itself?
I think that there are still some misconceptions, I suppose, about LGBT people, and a lack of awareness and understanding about why we need to monitor this data around sexual orientation, gender and trans status. So we unfortunately don't know anything about the number of LGBT people that were hospitalized or who have died from COVID because we weren't collecting that data. And yet, as we've already talked about, we know that LGBT people are more likely to have certain pre-existing conditions, to have a disability. We know about certain behaviours around smoking and substance misuse, minority stress, etc., which we think would be of use to investigate in terms of COVID-19. What we do know, obviously, as Kamilla and Paul have spoken about, are the impacts of lockdown on LGBT communities. And our role in the LGBT health team is obviously is to raise awareness and lobby as much as we can. And we really, really value the surveys that have been done. So I just wanted to highlight the Intercom Trust in the Southwest, who did a survey into LGBT people's experiences that was particularly looking at people living in rural areas. And as my colleagues have said, there was heightened experiences of hate crime, particularly with younger people living in LGBT phobic households, so effectively having to go back in the closet for their safety. I think we look at issues around domestic abuse often through a kind of heteronormative lens, partner on partner violence. Actually, there's domestic abuse happening within family situations. And then also just to highlight another report, again from the voluntary sector, Opening Doors London conducted a survey of their older members, many of whom were shielding during lockdown. And, there's some really heartbreaking stories about those older LGBT people who were really isolated without their usual kind of queer support networks and often without close family members.
I remember back in 2019, there was a report from Dr. Justin Varney to the one of the government Women and Equality committees, and it showed a lot of data which would suggest there are certainly poor prognostic factors for COVID-19 in the LGBTQ plus community, which may be increased rates of smoking and lung conditions, or obesity and chronic health conditions. But also what we're hearing here is a lot of social determinants of health are hugely impactful. And I wonder, how has the pandemic potentially highlighted the current failings of our approach to LGBTQ plus healthcare, given the focus which we're now paying on these social determinants? Maybe we start with Paul.
I'm just looking at some of the questions actually, and Catherine, hello Catherine, has done a great link to some of this evidence that we are talking about that has been pulled together for an article on the BMJ. So I would urge people to look in the question and answers. I think it hasn't been. I mean, I think the reality is, Callum, that what you're hearing is a long catalogue of quite catastrophic health inequalities, quite catastrophic experiences of some of the most marginalized members of LGBTQ plus communities. And in an evidence-based arena of healthcare provision, because we're not monitoring the sexual orientation or the gender identity of patients coming forward, we'll never fully know the true extent of this. So you have to rely on the research reports that are being produced by charities to kind of give you a snapshot. But I don't think that it is being addressed, and I think it's only going to grow further. Certainly, if I talk to my colleagues in other LGBTQ plus organisations across the country, they're experiencing very, very similar increases in demand as we are at LGBT Foundation. And I think what we also have to take into account is the impact on our staff and our volunteers as well. So, you know, we have lost quite a few staff and volunteers in the last sort of like 6 to 12 months because they just cannot cope with the pressure. So it's not just the impact of stress on healthcare providers that we're also worried about. We're also kind of concerned about the impact on workers in the frontline in the charity sector. And one of the things I think we have proven beyond any shadow of a doubt during this pandemic is that the charity provided support services are absolutely vital and are as equal in importance to services provided by the NHS, is that we simply cannot sort of like, you know, ignore the fact that the LGBTQ plus charities are providing, you know, incredibly important and very much needed specialist services to members of our community in crisis, in need. But I think what's really concerning, as Lizzie was saying, is that because there is a systematic failure in monitoring sexual orientation and gender identity, we're not seeing the true picture of need. And I think it will only just grow as we kind of go forward. And I think that it remains hidden, invisible, until we move forward on sort of like implementing effective system-wide monitoring.
Anyone else like to weigh in on that? Kamilla.
Yes, I mean, I totally echo what everyone has just said. And I was just also reading Catherine's email, and it says there is no good information on incidence, prevalence, hospitalization, and death from COVID-19 in the LGBT people. But there also there is no data on prevalence and incidence of any diseases in the trans community as well, because there's no way that at the moment that we can monitor or identify who are actually the trans people. I mean, I've been working at NHS Act for the past 2 years, and we've been asking them how, you know, ways to actually to identify trans people within the GP community. And you know, the answers is that yes, we don't have to read codes and we don't have the necessary ways to do it. But this is 2021. You know, I mean, technology is so advanced, and technology can easily be adapted and can be introduced in GPs IMIS or System 1 system to identify trans people. And without identifying, trans people without data, it's almost impossible to actually to know the incidence and prevalence of any diseases within trans people.
Absolutely. And I mean, some of that goes even down to your basic history taking, I suppose, of are we asking patients if they're trans or not? Lizzie, you wanted to say something.
Yeah, I mean, I think there's also an opportunity to look at demographic monitoring across all equality groups. We've seen some progress in relation to movements like Black Lives Matter last year. COVID-19 has clearly highlighted inequalities facing a number of marginalised groups, and I think it's important that when we're talking about these issues, we look at it through an intersectional lens, and the more data we have about our patients, the better. But yes, we are working, as Kamilla said as well, with certain areas. So, for example, we are working with our mental health programs at the moment to bring in trans status monitoring, because we know that trans people are experience much higher rates of mental ill health compared to cis people.
And one thing which we do know for sure about trans people, of course, is that the waiting lists for gender identity services, which were already at a very difficult point, they seem to have lengthened. At least that's what we're hearing. Would Kamilla or Lizzie like to comment on that?
Yes, I can comment on that. Yeah, fortunately, that during the COVID pandemic, GIC services GIC clinics are still providing the services to trans people, and most of it are done virtually, which also can be a good thing, because like in Tavistock, we see patients from all over the UK, from Birmingham, from Wales, from Leicester. So instead of them coming over to the GIC clinics, we are not able to provide the services virtually. And this has increased a lot of satisfaction among trans people. So the services are still running. And the good thing too, that there are now GP-led services that is being introduced, and that they have started providing the services in all over the UK. For example, in Manchester, there's a GP-led service which started in December 2020, and there were 5 GPs working in the services, and there are also care navigators, which was employed by the LGBT Foundation. And it is a good collaboration between clinicians and LGBT Foundation in providing the services for trans people. The care navigators is just such a brilliant idea, and where they can facilitate a lot of discussions and and can give a lot of advice about social transition before they come and see the GPs, before they can start the hormone treatment. And so far, they've actually seen 300 people since they started seeing the services in December 2020. There's also GP-led services in Liverpool, and they started in April 21, and they have seen 304 patients, which is quite a good achievement. And there are also Trans Plus at 5016 Street, and soon there will be a GP-led service in Cambridgeshire, East Anglia, and also for the population in Norfolk. So there are actually some improvement and some something to look forward to in terms of providing healthcare for trans people, but it's still not enough. There's still 20,000 trans people waiting to be seen, and the waiting list is still quite long. It's about 3 years for to access treatment, and the waiting list 3 to 4 years. It is to me it is unacceptable, and I think we should do more to reduce this waiting list time. And a lot of GPs are not able to also provide services for trans healthcare, and some of them have even started initiating hormone treatment because they are competent enough, they are capable enough to they have the skills to start hormone treatment for trans people, and this is very encouraging. So, but still, there's still a lot of things that there's still a lot of room for improvement, because there's still 20,000 waiting to be seen.
I think one thing that does prompt is we don't need to always have sort of doom and gloom here. What services have thrived during the pandemic, particularly perhaps in engaging with the queer community? What lessons can we learn from, best practice, which we have seen? Perhaps Lizzie.
Yes, I would again kind of highlight some of the amazing work that's happening within our voluntary sector. So, for instance, that Opening Doors London piece of research that I mentioned, ODL work with a befriending group who were on the front line going out and supporting older LGBT people, often, as I said, who were shielding, immunocompromised, without internet access, and without close support networks. Another organisation I wanted to highlight was LGBT Switchboard in Brighton, who've been working on a vaccine buddy initiative for LGBT people who might be anxious or have concerns about getting the COVID-19 vaccine. So I think there are some really brilliant responsive kind of examples of that are happening within our LGBT voluntary sector that the NHS has a lot to learn from.
Perhaps, Paul, you might like to add to that.
Yeah, I mean, there's been some amazing work that's been happening right across the charitable and voluntary sector. And even though a lot of the social support groups were sort of like unable to meet in person, a lot of them have been able to reorganize their offer and provide support to people and reduce isolation online. Certainly my own organization, all of the services apart from our in-person services are now delivered online, and I say we're busier than ever. And there's a huge amount of online support provided by the LGBTQ plus voluntary and community sector. Telephone support. We developed something called Rainbow Brew Buddies, where we sort of like, partnered people up with somebody to kind of like, if they were on their own, that we recruited some volunteers who wanted to kind of like, do something. So there's been some tremendous work that's been undertaken. And also what we're finding is a lot of LGBTQ plus people really prefer to receive counselling and support services online or via the telephone, because it actually reduces their need to quite often, travel into city centres. It's much more convenient, it's much more accessible, and it's actually much easier for the therapist to kind of like provide that support as well. So definitely adversity has bred some amazing innovation. It's not a bleak story at all in that sense. I think the challenge is going to be about sort of like maintaining those services and properly funding and supporting those services. And when we see sort of like, some of the real challenges that we're seeing in terms of waiting lists for all kind of services rising, and sort of, the challenges that the NHS is facing over the next couple of years, I would hope that sort of like charity services and the continued support that they provide to communities of identity would be continued. I also think that the LGBT team at NHS England have been doing amazing work, and Lizzie, Tash, and Michael should really take a bow for sort of really putting LGBTQ plus issues on the agenda and lobbying really hard behind it. That sort of like investment is identified. I assume at some point we will talk about the NHS Rainbow Badge project, and the fact that Lizzie and her team have kind of like commissioned what essentially is an amazing piece of innovation work, building on sort of like the tremendous work that Michael and his team had done previously, and also working with a number of other LGBTQ plus charities, Stonewall Consortium, LGBT Switchboard in Brighton, and so on and so forth, in terms of working together to sort of like produce and develop a quality assurance scheme across the provider sector. So I think there's some really good stuff. There's some really positive stuff. We shouldn't say this is a bleak picture altogether, because it's not. But I think we mustn't ignore that we are facing. We mustn't ignore the potential challenges coming down the line of, the overwhelming health inequalities and the growing health inequalities that are being experienced by LGBTQ plus people.
Kamilla.
Yeah, I just want to add something. In my experience working in gender identity services, we are reaching out to more neurodiverse and disabled people through video consultations. The cohort of people who are not able to come in face to face previously, but now we're reaching out to more of them, and this is quite this is very encouraging and quite heartwarming actually to see them actually able to reach out to us, able to get that, to get the hormone treatment, to get the support in the trans journey. Yeah, this is one of the good things that comes out during this pandemic. Yeah. And also community services, like for example, like Spectra, like where I'm a board member at Spectra, and we are seeing more and more neurodiverse, trans and non-binary people are joining in our support groups virtually, and we run these programs like every week or every once or 2 weeks, and the uptake is very, very encouraging. So it's very good to see that.
I think we've had an excellent segue from Paul there to ask Lizzie about the the future of the Rainbow Badge project, but also to address whether or not there's sort of any resourced NHS plans looking forwards to learn from what we have identified during COVID.
Yeah, thank you. So yeah, I think although we've spoken about monitoring and data collection, that can't happen in a vacuum. Even if NHS England does at some point make a top-down kind of mandation to trusts that we have to be collecting this, that doesn't actually solve the problem. And so it needs to kind of happen as a package in terms of addressing people's attitudes, awareness of why this data is important, etc. So the NHS Rainbow Badge, as many of you will know, was started by Dr Mike Farquhar at the Evelina Children's Hospital, and it's a badge worn by NHS staff to show that they have made a pledge to be a safe and supportive person for LGBT patients to speak to. We love the badge, but there had been some critique that it needed to kind of go further to address some of the real needs and concerns of LGBT patients. So as Paul has said, we have invested in a project which is called Phase 2 of the NHS Rainbow Badge, and again, as Paul described, it's a benchmarking scheme. So trusts that participate have to go through a self-assessment and a survey of staff and patients in order to identify specific actions that they need to take. That looks at things like LGBT inclusive policies, the environment that they're working in, staff education and awareness, LGBT leadership, support for LGBT staff networks, and then once they've gone through that process and had support from the partnership consortium of organisations that will be delivering the scheme, they receive a bronze, silver or gold award. But it's a continual kind of active, it's not just that you get the badge and then LGBT inclusion is done and ticked off. It's a continuous improvement initiative, and that partnership of providers that we've commissioned is the LGBT Foundation, Stonewall, LGBT Consortium, Switchboard, Brighton, and the National Association of LGBT Doctors and Dentists. I hope I haven't missed anybody. But yeah, we're really, really excited about that work, and hope to be rolling out more next year across even more trusts.
It's coming again and again about how vital it is to be working with the queer community and not just sort of taking over for them. And so I wonder then, given the mistrust which there is between the queer community and health services, how is it best to perhaps enable people to access services, potentially through the online lessons which we learned from COVID, and also in person as we potentially come back out of this pandemic? Lizzie, if you'd like to go.
I was actually going to suggest handing over to Paul at this point, because I think one of the best examples we've got is trans-led services at Indigo Gender. And I think that is, the best possible way that we can deliver services is by LGBT people for LGBT people. Paul, did you want to say anything about the Indigo model?
Yeah, no, very happy to do that. I mean, I think the Indigo Gender services is exactly what Lizzie just said. It's designed by and for trans and non-binary people, and so we've been working with colleagues at NHS England for nearly 5 years now, in terms of sort of like creating the evidence base, and sort of like organising co-design and co-produce workshops that help sort of like develop the specification, and then there was a very thorough kind of procurement exercise, and LGBT Foundation with our primary care partner GTD Healthcare were successful in setting up the Indigo clinic in Greater Manchester. We had nearly 700 patients transferred to us from the waiting list in December of last year, and as Kamilla said, we've seen just over half of those patients within the first sort of like 7 or 8 months. So we're working at tremendous pace, but we're working safely, and we're working within proper protocols. We have 5 GPs, we have a number of speech and language therapists, and we also have a number of psychological therapists as well. And again, as Kamilla mentioned, we have the care navigators, all of whom are trans or non-binary, and they support the patients throughout their entire journey. So even though the GPs have only seen about half the patients, every single one of the patients that were transferred to us have actually been sort of like connected with and supported by a care navigator. So we are supporting trans and non-binary people through the process that is laid down by NHS England, but also making sure that they can self-determine what they might need, and we're putting people in touch with support groups and sort of like trying to resolve some of the other issues that might be present in people's lives. And so I think as a model it works really, really well, and certainly the feedback we're getting is phenomenally positive, and people feel really supported and looked after, because of course when we talk about waiting lists, and Kamilla mentioned that you might have to wait at least 3 years for your first appointment, what you forget in all of this is that from your referral from your GP to your gender identity clinic, those 3 years you might have absolutely no contact with anybody. And then when you've had your first appointment, you might then wait a considerable period of time for any follow-up appointment as well. So it's not just the 3 years, it's actually something much bigger than that and much longer than that. And actually I've seen that people can sort of like spend a decade or more kind of going through the system. So I think that we just need to take into account the psychological impact that has, and it's unsurprising that trans and non-binary people have some of the greatest needs in terms of mental health, drug and alcohol, domestic abuse, and so on and so forth. It's unsurprising that people are feeling really, really excluded and really marginalized and really ignored by the system, because they are. And not only that, they're experiencing quite acute discrimination and prejudice within society more generally as well. So I think that that's what's important for us to kind of like keep hold of, is the sense that actually LGBTQ plus people can not only self-determine, but they can also self-organise, and they can actually meet their own needs. I also would just mention here Pride in Practice in primary care, where we work with GP surgeries and other primary care providers to again go through a self-assessment process and improve access to and services to LGBTQ plus people. And the evidence from the GP survey suggests that people, particularly in Greater Manchester, LGBTQ plus people in Greater Manchester, are less likely to feel excluded by healthcare providers. And I think quite often, it's not that we've got lots and lots of bad healthcare providers in this country. I don't think that's the case at all. I think what we often have is that people that feel out of their depth, or they don't have have confidence or they don't know what to do in situations. And I think for some clinicians, not knowing what to do in a situation is alien to them. And so therefore that can come across sometimes as being rude or exclusionary, as opposed to just being that somebody doesn't know what to do. But what we found with Pride in Practice, when we work with clinicians, we work with receptionists, when we work with practice staff, is that actually their attitude towards LGBTQ plus people changes quite fundamentally, and what can often appear to be quite insurmountable problems can actually disappear instantly when you bring people together to work together and treat people with dignity and respect, because that's fundamentally what we're talking about here. So I am an optimist. I am an optimist about sort of like, you know, the future. I am an optimist in terms of things improving and changing for the better for LGBTQ plus people. I don't think we're there yet, and I think that there are some really extreme examples that we continue to hear about. But ultimately, I think we're moving in the right direction. What we need is for that to be kind of recognised. You know, I'm really conscious that there was a research award scheme called the UKRI COVID Research and Innovation Scheme that was launched last year. In 413 awards, only one of them went to look at the needs of LGBTQ plus communities. So I think that that's what we've got to alter. We've got to alter access to research. We've got to alter access to sort of like, you know, positive, innovative ways to kind of move forward. And we need to make sure that we're collecting really good evidence through monitoring to sort of like really clearly show the needs of LGBT people in all their stark reality, so that we can then address those health inequalities and move forward positively.
And again, this is showing that what we really need to do is focus on the entire LGBTQ plus community in an intersectional approach. So for queer people of colour, what specifically are we doing to help their outcomes, especially given we know that, you know, with COVID had worse outcomes for people of colour as well?
Is that a question to me or to somebody else?
Well, I think it's for the panel to answer. We're all from there.
I would agree with you. I feel I've said quite a lot, but I would agree with you. I think there's some really good, very small fledgling projects that are working with queer, trans and intersex people of colour groups within organisations, but it's very, very unfunded and it's very, very ignored. I think that the needs of queer people of colour need to be addressed. I think, you know, intersectional identities is absolutely key for us to look at the most marginalised people within our communities, or people that are experiencing multiple discrimination. I agree with you, Callum. It needs to be looked at urgently, but I feel that Lizzie and Kamilla should be given a chance to speak as well.
Kamilla, you did raise your hand a second ago.
Yes, I did raise my hand. Yeah, I just want to extend to what actually Paul has said about the GP-led services. I think the way forward is not just a GP-led service, but multidisciplinary team, because other services are now provided by not just GPs, but also by nurses, practitioners, by psychologists. So I think, and psychiatrists, and I think this is the way forward, that everyone works together to provide the best service to the trans community. And there are select GP-led services that is happening in this country. But there is what Paul has just highlighted, that once you see by the GIC, but then there is a gap that, the next appointment is probably sometime 6 months to a year's time. So there is a gap of this, that the trans community need more support. And I have actually proposed that, that the way forward, I propose this to the RCGP, that the way forward is actually to introduce GP with special interests that can actually, provide this interim service, where they can actually provide more support, and they can also help to monitor the hormone treatment, take the blood test, monitor the levels, and adjust them accordingly. Because it's like waiting for all the GPs to do it. Sometimes it can, it doesn't happen for one reason or the other. So I think this interim service, which is like GP special interest, is probably a way forward to provide a better service for the trans community. And GPs nowadays, they all would like to have a more of a portfolio career, and so this can provide, enormous opportunity for GPs for their own development. And we don't really need that many GP with special interest because these services can actually be provided through the primary care networks. And as you know, the GPs surgeries now are more united, and then they all work together. So GP special interest can provide a service for for the whole borough, because it is easily been done. It can be done. So that I think, to me, that's probably a way forward to provide a better service for the trans community.
And Lizzie, if you'd like to add in anything, and then we can move on to some audience questions, perhaps.
Yeah, I mean, we have been talking to colleagues who are working on the Race and Health Observatory at NHS England. So this is looking at the health inequalities experienced by people of colour. And also we work closely with the Workplace Race Equality Standard team. And I think that there's, a lot to be learnt from them, actually, because they really do already have a model that we would quite like around monitoring ethnicity of staff in the NHS and following their career progression and looking at ways in which organisations can be anti-racist. So I think it's really important that we don't wait and kind of say, oh, well, we're working on this issue now, so we'll look at LGBT people later. That we look at all of these issues in an intersectional way. It is very difficult, though, often times when budgets are divided up in different ways, and there are different kind of priorities that trusts have to focus on.
Okay, well, thank you all very much. There has been a very interesting question come in, which I hope one of us might be qualified to answer, though I'm not quite sure who it would be. And it's from one of our consultant forensic psychiatrist colleagues who's commenting on the health and well-being of LGBTQ+ prisoners. Obviously a group which is very often forgotten about and very often marginalized, and there's a huge amount of stigma in that area. So given the data is poor, pardon me, and we're seeing increasing harms, I wonder if anyone has the capacity to comment on what we could be doing going forwards, or what we should be doing going forwards.
Well, I'll start then, because we're running out of time and we haven't got the time for the silence. So I'm not equipped to answer that question. I did make a note of it. I did take a photograph of it. Brad, thank you very much for raising it. It is very, very concerning. I wonder whether, Callum, there's a way of kind of capturing a lot of the questions in the transcript. I know that sometimes that doesn't happen, but there's some really good points being made in the transcript, some good ideas, some good sort of like suggestions of moving things forward. So that could be, if we could somehow capture those, that would be really, really helpful. And I'd certainly welcome getting access to some of those questions in terms of thinking about what to do. But I've certainly I'm going to take that back, Brad, and have a look at that and have a bit of a think about that, because I was aware of some of it, but not aware of all of it. But I think that this goes to the heart of why we need to have good monitoring, so that we can start to identify where there are trends emerging. So as Brad's saying, there are increasing numbers of men who have sex with men that are getting involved in chemsex and then actually kind of like becoming involved in the criminal justice system as a result of that. We will never know that until such time as we monitor it, or that anecdotally someone like Brad mentions, or I'm seeing more people that fit remain hidden. That's how things remain completely below the radar. So I think that there are increasingly issues like that are impacting and affecting queer people that not necessarily we're becoming aware of. So I think that monitoring for me helps to sort of identify the trends and identify the issues.
Absolutely, I think that's a really good place to start. And there's another question which I would like to raise. In terms of the pandemic response, of course, we've mentioned rainbow badges recently. We know that the rainbow now certainly has a different meaning. That I think we've all seen that, we've all heard that from patients. I wonder if Lizzie has a comment on what she thinks that could be done in order to sort of, retake back what was a political symbol for the queer community and has been co-opted.
Yes, we've talked about this a lot actually, and I think it's a tricky one because I think the rainbow design that kind of emerged through COVID did become a real symbol of hope for lots of people, you know, with what we were seeing with people putting pictures in windows and that kind of thing. And it wouldn't have been a good thing to probably start sort of criticizing that. However, I think it is an opportunity to remind people of the significance of the rainbow and what it means for LGBT people. We, during Pride Month, started a hashtag under the rainbow to encourage NHS LGBT colleagues, or anyone really, allies as well, to talk about on social media what the rainbow signifies for them. You know, because as an LGBT person, I have that experience myself. If I go into a service and see a visual symbol, whether it's a poster for the LGBT Foundation or a picture of a rainbow or a trans flag, then I immediately feel more relaxed and immediately feel slightly more confident that they might be able to understand my needs. But yeah, I think it's an opportunity for a kind of teachable moment, and also with the launch of phase 2 of the Rainbow Badge, hopefully, you know, we'll be able to do some comms messaging around that to again to kind of highlight the meaning behind the flag, and also to talk about things like the Progress Pride flag and the intersex flag.
Absolutely. Kamilla.
Yeah, I just want to answer to one of the questions that were in the chat group by Michael Hendrick. I just want to respond to his questions about are we not concerned about lack of action by the government not banning gay conversion? I don't know whether either of you actually realize or read about the or seen anything on Twitter about the BMA annual meeting recently, where 1/3 of doctors have voted against a motion calling for BMA to take a more active stance against conversion therapy for LGBT people. And that means 30% of the doctors in that meeting have advocated conversion therapy. And they're advocating for conversion therapy, and they're doing so on the basis of transphobic views. And to listen to my colleagues, you know, supporting conversion therapy and expecting people like me to go to some conversion therapy. I'm not sure what kind of conversion therapy they're talking about, but in other countries that conversion therapy involves torture, you know, staying in a mental institution, unnecessary psychotherapy and psychological interventions, which are harmful. And I don't know, what did I do wrong? You know, it's like, I know, I mean, this is very much against my, you know, against me, and to see my colleagues advocating for that is shocking. And it's actually quite painful for me to listen to all this.
I don't think there should be any doubt that that certainly was an attack on the queer community, because, you know, the UN Special Rapporteur on Torture says that conversion therapy can amount to torture. We've seen the harms it does to queer people. We've seen the outcomes from it. It certainly is an attack on the queer community and is completely unacceptable. Lizzie, your hand's raised.
Yeah, just to echo that, we absolutely welcome the commitment to ban conversion therapy, and obviously think it's super important that the legislation wording covers both sexual orientation and gender identity for all people, and that it's across all settings. So obviously not just religious and faith settings, but also within healthcare, where we know it does still take place in certain areas. The government consultation for this new legislation around conversion therapy is due out very soon. It will be open for 6 weeks, so I would encourage everybody to reply.
Okay, well, I think that is about all that we have time for, unfortunately. These questions are saved in the Zoom account afterwards, so we can all take a look at them and hopefully be able to get some more answers for you. I'd like to close this just with a few thoughts. We know that discomfort with queerness has rendered the LGBTQ+ community more vulnerable to disruptions and impact that COVID has had across society, not just in healthcare. And we've heard how some of those harms have manifested today. There's the lack of trust between our two communities. There's a problem with access and waiting lists. There's a lack of monitoring, and we still do not take a sufficiently intersectional and social harm focused approach. We have also heard some of the positives. There's been an increase in community working, and hopefully that will go some way to bridge the lack of trust between us. There's been an increase in charitable responses who've been doing phenomenal work and really picking up where the institutions have failed. And there's been a lot of innovative practice which has come out from this pandemic. If I can leave you with one message, it is this. I think we begin LGBTQ+ inclusion by doing the work to unpack the identities of those under that umbrella. There is no monolithic queerness that one can simply claim to advocate for, do a single training plan for, and then be finished with. The ways in which sexual orientations and gender identities interface with the harms of COVID vary depending on the interactions with other factors, including their socioeconomic status, disability, race. Pushing for queer inclusion and progress should not focus on the individual sexual or gender identity, but through a deconstruction of the various factors which marginalize queer people and make them vulnerable. Queerness is a challenge to the established normative structures. It's not an adjective, it is a verb. And so thank you very kindly for coming along to this question and to this webinar and submitting for all your questions. I'm only sorry we didn't have more time to get into it all. And thank you so much to the panel, Paul, Lizzie and Kamilla, for all your time and insights. Next week, the Royal Society of Medicine have a special extended episode of the COVID-19 series called Vaccines, Variants and Infection, the Position This Winter, which is a 3-hour paid-for program about the current situation with COVID as we approach winter. Guests will include Dame Professor Sarah Gilbert, Professor Sharon Peacock, Professor Sarah Walker, and Professor Peter Openshaw, and it promises to be very exciting. So that will all be from us, and I hope you have a lovely rest of your day, and thank you very much for coming. Goodbye.
Bye, thank you.